Dear ladies and gentlemen, good morning, good evening, good afternoon, or good night, wherever you are. We are really very happy and honored to host this webinar that is really global. We are receiving a lot of message from Japan to North America, South America, Africa, Asia, and we are very proud as member of the Global Congress community of hysteroscopy that we are really global. And we were a little bit scared at the beginning when we arranged this webinar. And please let me thank Medtronic for supporting all the organization of this webinar, and Yami and all the organization of the Global Congress of Hysteroscopy for supporting with the platform this meeting. I was saying that we were a little bit concerned because probably we were so brave at the beginning just to arrange a meeting on probably one of the most old-fashioned and boring topic in the hysteroscopic field, the endometrial biopsy. We generally speak about uterine malformation, myoma, ablation, innovation, and we are still speaking about endometrial biopsy. The fact that there are nearly 200 people already connected, it means that there is a huge interest towards this topic. I want to give the speech to now he became one of my best friends. I speak with him more than with my wife, and Sergio Haimovic, who will give you some details about this meeting. And I'm sure, because I've seen the presentation, that you will really enjoy this meeting. And we will give now the speech to Sergio, and then Sergio will give back to me, and I will present the first speaker. Come on, Sergio, stage is yours.
Thank you very much, Attilio. It's a great pleasure to be introduced by you. I want to welcome everyone in the name of GCH. As you know, many of you have been following us for the last years, and you know how much we believe in continuous medical education. So this initiative, together with Medtronic, it's a great initiative because they also believe in the same philosophy of investing in education for all of you. So this is one step more forward in bringing hysteroscopy in a global way. So regarding this webinar, this session that we are going to start, some small things. First, we are going to answer to all the questions at the end of the session. There's going to be a discussion over there. So in your screen, you have the Q&A, questions and answers. So don't send your questions through the chat. Just send it through that channel, questions and answers, Q&A. Second, there are going to be some questions at the end of each presentation. 3 questions at the end of this presentation, live questions. So we would like you to answer to them. They are very important for us to get this information. They are very easy, but it will give us a lot of information regarding our next steps, the future. And the last thing is, if you want to listen to this in Spanish, you have an icon of over there on the right side, on the right part, in the lower part of the screen, in the right side, in which you see, the word, a small word. You click there and you choose Spanish. You have for the first time, we have a Spanish simultaneous translation during the whole session. So with no more dilations, I will give you back the word, Attilio, so you can introduce Brunella if you like. And thank you all for being here with us.
Okay, thank you, Sergio, for all this information. And now the show is beginning. So it's a real pleasure and a honor to present what has been my assistant for the last 15 years, but is the typical example of the junior who becomes better than the senior, because Brunella did her training with myself in hysteroscopy, but also had very good master in ultrasonography as Katerina Exakoustos, and so is the typical modern gynecologist, which combines both skills. his endoscopic skills and sonographic skills. I wouldn't add any other words because, of course, I am on part because I have seen Brunella growing up in last years. I'm sure that you will appreciate her presentation. And so let's give the speech to Brunella. Brunella, stage is yours.
Thanks for the presentation, Attilio. Thanks for the invitation. So, I'm honored to open this great webinar, but today my work is very hard.
No.
¿Se quedó sin comunicación?
Can you hear me?
No, Sergio. Vedi la comunicazione c'è?
Sì, Attilio, maybe she can use yours.
I don't know, ci va la tua presentazione? Perché c'è la connessione? Aspetta. È sul wifi.
We apologize for this is the problem of the direct when we use for the first time translation, although there's no their fault, but we will solve it in a moment. Just ask you to be patient.
Sì. Fai. Vuoi fare? Io non sento neanche io più Sergio. No.
Okay.
Okay.
Okay. Can you hear me?
We can hear you. We can hear you, Bruno.
Okay. Can you see my slides?
You need to share your screen again.
Okay. Okay, now I share my screen. So we can start.
We see you.
Yes, okay. So I am honored to open this great webinar, but at the same time, today my work is very hard. Firstly, because I have to introduce the kings of the global community hysteroscopy. And then because I would like to protect a diagnostic tool as ultrasonography that clearly laws in this context of endometrial biopsy. But I'll try to do it. So I started to underline that the use of the ultrasound in the evaluation of the endometrial pathologies was introduced in the last decades of the 20th centuries. And until the first years, it represented the gold standard of uterine imaging, a painless, low-cost, and non-invasive approach with a good accuracy. Also, at the beginning, it was not so effective. You can see these images. Maybe these images we could obtain in that period, almost all black. Maybe we have to imagine the pelvis or the endometrial pathologies. But in the following years, it becomes better and better, thanks to diffusion of the technical innovations such as 3D technique or color and the power Doppler and the sonohysterography. The clinical relevance of ultrasound has grown until getting this type of images from 2D to 3D. Today, we can obtain this quality So more and more information also regarding the endometrial pathologies. So also Vaz knows the GYNeACADEMY group, our teachers, and a group of the most experienced ultrasonographists that defines a consensus on terms, definitions, and measurements that may be used to describe the endometrium and the uterine cavity. On grayscale sonography, on color flow imaging, on sonohysterography, and hand in hand with the technological innovation, the definition of ultrasound criteria for the evaluation of the endometrium increased the diagnostic power of the ultrasonography. So the GYNeACADEMY group show us, explain us which are the characteristics that we have to evaluate in the endometrial pathologies. So we know that we have to study the thickness, so the echogenicity, the endometrial midline, the endometrial myometrial junction, the color score. So all of us are able now to describe these images. You see on your left, you have a normal endometrial, on your right, a polyp. In the center, you can see an evident endometrial cancer, also without color and power Doppler. But our daily clinical practice is not so easygoing. So we have to underline that ultrasound and some limitations. Because if all the endometrium cannot be visualized, the exam, the ultrasound is not conclusive. We have to stress the concept that all the uterus should be scanned from the left to the right, from the fundus to the cervix. And if we have some difficulties, as in this example of adenomyosis or fibroids, we cannot study all the endometrium. And so in this situation, due to cavity distortion or stretch uterine position for the presence of deep endometriosis, maybe. And if endometrium has the similar echogenicity from the surrounding myometrium, in this situation, the ultrasound is not conclusive. And we can overcome these difficulties, starting by the endocervical canal to identify the endometrial line, so moving up. The second limitation of the ultrasound is rather a low specificity. A thick endometrium doesn't mean endometrial cancer. We know that thick endometrium can be caused by polyp, intracavitary fibroids, hyperplasia, endometrial cancer, but also an artifact. So in this situation, the color and power Doppler can help us to distinguish these pathologies. A further limitation of the ultrasound is the need to correlate this exam to the clinical data and also to other technique. In fact, this is the last paper of the GYNeACADEMY group published in 2020. In this paper, they find other criteria to define, to exclude endometrial cancer, depending on the age of the patient. So depending on the symptom, so before and after the menopause. If you see this image with 2 millimeters of endometrium in a woman with postmenopausal bleeding, what do? I think all of us required an hysteroscopy, so another complementary exam. So as Icaro, sometimes ultrasound make diagnosis maybe too far from its possibilities. And I show you some cases. This is the last cases that I show you. In these cases, we have some anterior fibroids, and these anterior shadows cannot visualize the endometrium. So at the hysteroscopy, we can see that we have multiple polyps with also irregular vascularization and necrosis. In other cases, she is an infertile woman with this scan. At hysteroscopy, we diagnose a severe chronic endometriosis that we treat. And with these cases, I want to underline that only the hysteroscopy can diagnose a severe Asherman syndrome that on 2D and 3D ultrasound can appear as a normal or a tubular cavity. But what can be hidden by ultrasound? What scares us mostly? Sure, the malignancy. Sometimes with this image, with the good ultrasound, we can have these results, this hysteroscopic image with this histology, hyperplasia with atypia. So pay attention. All this is related to the fact that ultrasonography, unlike the hysteroscopy, cannot enjoy of the direct vision of the uterine cavity. And despite being an invasive method, the hysteroscopy remains the most accurate method for diagnosis of endometrial pathologies. Most of all, hysteroscopy allows to perform biopsy of suspicious area under direct visualization. So if you can perform in your ultrasound office endometrial sampling with blind technique, we have to know that this blind technique is associated with higher risk to miss a focal endometrial lesions. But which are the difference between these two exams, ultrasonography and hysteroscopy? In a hand, transvaginal ultrasound has a higher safety, acceptability, and feasibility. But on the other hand, hysteroscopy is the only exam that allows a direct endometrial biopsy and allows in the same time to treat these pathologies. And this prospective study, they compare transvaginal ultrasound, sonohysterography, and hysteroscopy in diagnosis of the all endometrial pathologies, and they conclude that only the hysteroscopy can distinguish between hyperplasia and cancer, and only hysteroscopy can diagnose in detail Asherman syndrome. And in the last paper, in this paper, they compared sensitivity and specificity of both exam with the higher value for the hysteroscopy, and they conclude that we can use both sequentially or in combination. But also hysteroscopy is the most accurate exam. We know that it is invasive and more expensive than ultrasound. So ultrasonography is trying to evolve itself to improve its diagnostic power. So was born the virtual sonohysteroscopy, a new approach to evaluate the endometrial cavity that consists in acquired 3D volume during the sonohysterography, so during the insufflation of fluid. So it's fundamental, the distension of the uterine cavity. So you can imagine the limits of this exam, the distension of the uterine cavity, for example in cervical stenosis, and the lack of the histology. So the best can be obtained only from the fusion of the ultrasound and hysteroscopy in an outpatient setting, as resumed in this idea of digital hysteroscopic clinic that we try to achieve in our clinical practice. We performed ultrasound and hysteroscopy every day, every time, at the same time to diagnose and to treat all the uterine pathology. Thanks for your attention. And now I introduce Luis Alonso Pacheco, one of the most famous hysteroscopists, one of the co-founder of the global hysteroscopic community, Thanks to him, we have every month a hysteroscopic newsletter that is a guide for all hysteroscopists. So let's go, Luis.
Thank you, Brunella. Thank you for your kindly introduction. I don't know if Sergio is going to put some questions before my lecture or not, Sergio?
No, I'm copying the questions for the end. So we will finish and we have the discussion. I will ask each one of you the questions and we will try to answer them.
Okay, so I will share my screen. Yami, if you can let me share my screen, please. And I'm going to talk about why to perform an endometrial biopsy. Here it is. Okay. I have no financial relationships to disclose regarding this lecture. And I'll try to give you an answer to this question, an answer to why to perform an endometrial biopsy. And you know, sometimes when we face with a medical condition, we can only have a provisional diagnosis. Provisional means that we are not 10% sure of the diagnosis, and we need to get more information. And sometimes to get that information, we need to take a sample of the tissue, take a biopsy. In our case, as gynecologists, we can take biopsies from the vulva, from the vagina, from cervix, even from inside the uterus, even from the endometrium. And as you, as gynecologists, well know, that sample from the endometrium can be obtained by different methods: endometrial office biopsy, D&C, or hysteroscopy. But most of the time, we choose a blind procedure, endometrial office biopsy, that can be easily performed in most patients and by most gynecologists. Sometimes we perform a D&C, dilatation and curettage, or we can even perform a direct hysteroscopic biopsy. I am not going to evaluate the diagnostic accuracy of the different methods, but the indications. I mean, why to perform this kind of endometrial biopsy. And here you have a list with the different indications, and those indications, there's a lot of them, depends on the age of the patients, on the clinical symptoms, and on the result of the complementary test, as Brunella showed us before in her great lecture. So, in summary, with all those results, we have in postmenopause women. In the postmenopause, most guidelines recommend to perform an endometrial biopsy in those three situations. Any woman with postmenopausal bleeding who is not receiving hormone replacement therapy. A postmenopausal bleeding is defined as any bleeding that happens after 1 year of amenorrhea in a woman who is not receiving hormone therapy. And we perform this biopsy because about 7% of such bleeding is caused by malignancy, is caused by cancer or precancer lesion. So postmenopausal bleeding should be considered to be from endometrial cancer until proven otherwise. The first thing that we have to discard is an endometrial cancer. Second, most women taking cyclic combined hormonal replacement therapy experience regular withdrawal bleeding. This is something normal. Patients with irregular bleeding not associated with progesterone withdrawal should be considered to have abnormal patterns of bleeding and should undergo endometrial sampling. So this is the second point in the postmenopause. And the third one is in those women who are taking continuous combined hormonal replacement therapy, the endometrium often becomes atrophic, and these women become amenorrheic. 75% of these women develop amenorrhea after 6 months of treatment. If bleeding continues beyond those 6 months, it should be considered abnormal and an endometrial sample should be taken. So those are the 3 situations in which we must take a biopsy, an endometrial biopsy, in a postmenopause woman. In the perimenopause or premenopausal woman with abnormal bleeding are at increased risk of endometrial cancer, secondary to their age and the anovulatory cycles. All women with abnormal uterine bleeding in the perimenopausal period require an endometrial sampling. And the most worrying patterns are persistently increased menstrual flow, decreased menstrual interval, and intermenstrual bleeding. And under 45 years old with some risk factors for endometrial cancer and patients with abnormal uterine bleeding, those need to be taken as a sample, a biopsy. The most important risk factors in those patients in premenopausal women, the most important is the irregular menstrual cycles, which are associated with a 40% risk of abnormal result on the biopsy. Other group is those patients with we call high risk asymptomatic women. And there are patients who have endometrial cancer risk factors. Those patients, even if they are asymptomatic, could benefit from an endometrial biopsy in order to rule out an endometrial hyperplasia or an endometrial cancer. Other important group is those patients who are taking tamoxifen because of the estrogen-like effect of this tamoxifen on the endometrial lining. Any patient taking tamoxifen who experienced abnormal vaginal bleeding should have an endometrial biopsy. Other important group is that one composed of women who have been treated for an endometrial hyperplasia with any kind of hormone therapy, and those women require a follow-up endometrial biopsy in 3 to 6 months to be sure that the hyperplasia has regressed. Other group is the woman with Lynch syndrome. It's an hereditary non-polyposis cancer colon, and those require the test of the endometrial cancer. The current American Cancer Society guideline recommend the screening via endometrial biopsy starting by the age of 35 years or and performed every year. Another group, postmenopausal woman without vaginal bleeding. If the endometrium is over 11 millimeters, a biopsy should be considered, as the risk of cancer is 6.7%. Whereas if the endometrium is less or equal 11 millimeters, a biopsy is not needed, as the risk of cancer is extremely low. Other important group is in those cases in which we have an abnormal pap smear test. In postmenopausal women, the presence of any endometrial cell on pap smear is an indication for an endometrial sample. And in all women, the presence of atypical endometrial cells on pap smear need to be tested, and those women need an endometrial biopsy. And the last important group in which we usually use this sample of the endometrium is patients in any treatment of fertility. The endometrial biopsy is also used in patients with fertility problems, in patients who are going to room for an IVF cycle, in order to assess the endometrium and in order to increase the treatment success rate. In those patients, 4 characteristics of endometrium are evaluated: the stage and maturity of the endometrium, the receptivity, and something called window of implantation, the microbiome, and the presence of plasma cells to check for the chronic endometritis. Regarding the stage and maturity of the endometrium, you know that the endometrium is a sensitive target tissue for hormones and that it is able to modify its structural characteristics. In fertility patients, the hormonal therapy can result in an abnormal histologic pattern that can affect to the embryo implantation. Sometimes it is important to take a biopsy in order to have an histological exam of the tissue to assess the maturity of the endometrium and the synchronicity between the menstrual cycle and the endometrium. Regarding the endometrial receptivity test, you know, is something called the ERA test, is a molecular diagnostic test that is used to know the receptivity state of the endometrium. This test tries to find something called the implantation window. I mean, the period of time in which the endometrium is receptive. In this period of time that usually begins between 5 and 7 days after the ovulation, the endometrium has already acquired the morphological and functional characteristics necessary for the embryo implantation. We also perform tests or endometrial biopsy to know the endometrial microbiota. And for many, many years, gynecologists were convinced that the healthy uterus was sterile. But today, we know that, like the normal vaginal microbiota, the endometrium is of a healthy and asymptomatic woman is often dominated by lactobacilli. An abnormal endometrial microbiota has been associated with implantation failure and pregnancy loss. It is important to identify this endometrial dysbiosis to assess the uterine microbiota in infertile patients and to restore the normal endometrial flora in order to improve the pregnancy rates. And the last point is this one, is the chronic endometritis. Chronic endometritis is defined as a localized inflammation of the endometrial mucosa, characterized by the presence of edema, increased stromal cell density, dissociated maturation between the epithelial cells and stroma, and of course, the presence of plasma cells infiltrating the stroma. Chronic endometritis is associated with a poor reproductive outcomes, including implantation failure and recurrent pregnancy loss. There is a molecular test that can identify the pathogenic bacteria that cause the chronic endometritis and also gives information about the most recommended antibiotic treatment. In summary, here you have the different indications of when to perform an endometrial biopsy. Postmenopause woman, any uterine bleeding. Premenopause woman, depends on the age, over 45 years old with abnormal uterine bleeding, and under 45 years old with abnormal uterine bleeding and risk factors. High risk woman, ultrasound findings with an endometrial over 11 millimeters in postmenopausal woman, abnormal pap smear test, and in cases of fertility. I'm sure that in the next year we'll have more and more indications. And if I have to choose one sentence to give an answer to the questions of this lecture, why to perform an endometrial biopsy, my answer would be to be sure. But to be sure, we have to be accurate in taking the biopsy. The next speaker will give us some keys to be sure to take the sample in an accurate way. Thank you for your attention to all of you. And now, my good friend, Sergio Jaimovich is one of the great minds that I know, one of the best hysteroscopists in the world, is going to continue with his lecture and he's going to explain us some things about the D&C, dilatation and curettage. It's your turn, Sergio.
Luis, thank you very much for your kind and flashing your kind introduction. I think that I'm going to talk with you about the D&C, a never-ending story. Why that? Because do we still need to go and perform D&C as we perform right now? So I would like to go with you and understand what D&C represent today and to see if there are any alternatives. So I believe that if any of you like to perform D&C, you won't like much my presentation. First, I have to say that I don't have any conflict of interest to declare regarding this presentation. So my question is, how did we get here? How we did arrive to the moment that still we are performing D&C? So I would like to go with you to understand innovation and what happened with the innovation. So medical innovation is something, so it's the creation of products or services that they transform and improve, solutions that improve the outcome for our health. But initially, what's the solution? What kind of solution? So we try to find solutions to unmet medical needs or unmet surgical needs. And where those ideas for giving a solution for an unmet need comes from? Mostly it comes from us, surgeons, physicians. We have ideas because we work every day and we see something that, oh, maybe changing this, it will be improve my work. Maybe changing this, it will make my work safer, or maybe I can do it faster, or I can create a new kind of device that will help us to improve our results. So we are the ones who bring mostly the solution. So I want to take you back in time. So those of you that don't recognize the picture, it means that you are less than 40 years old and you are still very young and lucky. So those of you who recognize that, this is from Back from the Future, movie from the 80s. So I'm going to take you back in time. Where to? To France of the 19th century. So we are going there to try to understand where D&C comes from and how it arrived to us. So let's try to see. This is the guy. This is the guy. Joseph Claude is the one. I believe he was like a Steve Jobs of gynecology in those years, because he was the one who is considered the undisputed founder of modern gynecology surgery. So I know that you are not aware of this guy Recamier, but he's also the first one to perform a successful vaginal hysterectomy for cancer. This is also a very important thing, but it's not the last. He really was an innovator. He introduced the colpotomy for the drainage of pelvic abscess. But you know what? He also brought us the speculum. He's the inventor of the vaginal speculum. This is what was a good patent, because this is something that all of us use. And the moment he introduced this new invention, he could see the cervix, and he was the one who invented the curette. And not only that, he performed the first curettage in 1846 in Paris. He was the first one to perform DNC. What's a real innovation at that time, because it was the only way to get samples from inside the uterine cavity. So, you know, whenever a new technology comes, there is another one who's trying to improve that. And usually it happens like that. And we see in hysteroscopy many improvements since Pantaloni performed in 1869, the first hysteroscopy. It changed a lot until today. But with the DNC, there was nothing changed in the last 175 years. The procedure is exactly the same, no improvement. Sometimes you use the ultrasound guided, but on the procedure, there is no improvement. We still use the same tools he used to use back there 175 years ago. So I want to show you this small video about the DNC. So you all know that you go, you put a speculum, and the first these things we need to do is tenaculum, and then we bring another tool, the hysterometer, to do the hysterometry. And suddenly it happens, and it could happen to anyone, and a perforation with the hysterometer. So now we bring the Hagar to do the dilation of the cervix. And again, when you use these tools, something can happen. And finally, we bring the curette. And listen to the uterus crying when you use this awful blind tool, the curette. And even with the curette, we can damage organs, like you can damage the intestine. So nothing changed. It's not a very safe procedure. And we are going to see, there is a lot of evidence showing us the many complications associated to this procedure. And we're going to see, first one, and the most light one, is cervical injury. Usually due to the tenaculum, and the most common one is the cervical injury due to laceration of the tenaculum. We say it a lot. You pull and there's an injury many times. Then the internal damage to the cervical canal or even the stroma because of the dilation of the Hagar of the instruments coming through the cervix. So there is also damage inside the cervix. Perforation, 0.3% in premenopausal, higher in postmenopausal, and if you perform a DNC after pregnancy, it's 5%. It's very high, and it's due to the use of mechanical instruments for dilation or going inside, as you saw in the video with the hysterometer. Adhesions, they go from 19%, and it can arrive till there's, depending on the series, until 40% after DNC. You may see adhesions. But not only that, look, when you find adhesions, around 90% of them, the reason is DNC. For any indication, the DNC is the reason of 90% of the adhesions we see inside the uterine cavity. So we cannot forget that. As we saw, you can also provoke injuries to other organs like the intestine or bladder, okay? And this is also important, more than 20% of reintervention, because, for example, when you do DNC for an abortion, even if it's a spontaneous abortion, many times there's a reintervention because there are retained products for conception, and patients need to go again through that, another DNC. Luckily, we are changing that. So you see that there are a lot of complications or associated with a blind procedure. So what can we do? Listen, we are changing things. This is coming from the NICE guidelines related to heavy menstrual bleeding. And look what they say. Importantly, blind endometrial biopsy should no longer be referred. We should no longer use this kind of procedures, blind procedures. So even for biopsies, we should do direct visual biopsies. And for concluding, we are going there. What do we have or do we have any alternatives? I believe we have alternatives to doing blind procedures. Look at this. This paper was published 23 years ago in the Journal of the Royal Society of Medicine, 23 years ago. And Claire Seamark, here you can see underlined, from all the evidence now available 23 years ago, it is hard to see any role for the traditional DNC. But not only that, my final sentence, coming from the same paper, after 150 years, the time has come to say goodbye to this procedure, to this operation. So I believe that what we are doing here with this session about biopsy 3.0 is the first step of leaving behind this kind of blind procedures and going forward into something that is safer to our patients, avoiding all those complications we saw here. And I think we are in front of a kind of small revolution in gynecology. So knowledge is experience. Everything else is just information. As before I finish, I want to invite you, because next month, May 2021, is the hysteroscopy month. Global Community on Hysteroscopy is bringing to you the Global Congress on Hysteroscopy 2021. It's free registration through this website, www.mygch.com, and it's going to be also with simultaneous translation into Spanish. So I would like to see all you there, because it's going to be great. And thank you very much for your attention. And right now, it's my turn to introduce the next speaker. I can summarize it by saying that he's a great professional, but an even greater person. But the formalities ask me to tell you that Tony Carunio, he is associated professor of OBGYN in the Miami University. He is in the Department of Obstetric Gynecology and Reproductive Science. And he is also the Minimal Invasive Gynecology and Robotic Division Director. So you're going to enjoy very much the next topics by Tony. So I leave you with him, and thank you very much for your attention.
Hi, Sergio. Thank you so much for your kind invitation. Let me start sharing my screen. Okay, can you see it? Do you guys see the screen?
Yes, perfect.
Okay, great. So first of all, it's for me a great honor and a lot of pressure to speak after all these great speakers, starting from Brunella, who did an impressive job, Luis, Sergio, who always, teach us a lot in these talks. And for me, and following Tilio, it will be really, really difficult. So it's an honor for me to be here. And I'm going to talk about the grasp biopsy, right? And I mean a simple, useful thing, because we will soon understand the role of hysteroscopy for the endometrial biopsy. And I'm going to start my talk with probably the most depressing slide that I'll present. And this is the actual truth. This is what's happening nowadays out there in the real world. About 65% of practitioners, after putting the hysteroscope inside the uterus, they see the Japanese flag, or they think they see something inside the uterus. They remove the hysteroscope and go for the polyp forceps for the curette. This is actually still happening about 65, 70% of the time. About 25% of us actually are using the hysteroscopic instruments, and it's about a 10% of us who are expert hysteroscopists and devote our career to intrauterine surgery. But as Sergio said, I mean, now the time has come when you see people like Dr. Frank Slofer, a well-respected director of the AGL, coming out with articles saying that the time has come to quit relying on blind biopsy. It's because he has solid evidence in his hands to say it. As Sergio already presented, solid institutions like the National Institute of Health from the UK, when they come up with strong statement like endometrial biopsy should no longer be offered. I mean, you hardly ever see an organization coming with such bold statement. It's because the evidence is there. I really have a hard time understanding how technology now have given us instruments that we can easily look inside the uterus with very minimal to none discomfort. And we're still wondering if we should look inside. Who in the hell will treat an ear infection without looking inside the ear of a pediatric patient or a colonoscopy? I don't understand why there is so much resistance to look inside the uterus, but things have changed. And sometimes we don't realize. And now we have here Pope Benedicto XVI and Pope Francis. And they're here in this talk, not because we need to pray to stop people to stop doing DNCs. It's because you'll understand this. Pope Benedict XVI, he was elected Pope in 2005, and he did something that never happened before. He stepped down alive, and then the Catholic Church elected Pope Francisco in 2013. He's been doing a great job. But this is why they're here. This is the day that they became Pope, right? The first day, the ceremony of the first day. Look in 2005 on your top right. There is probably one person here with a cell phone. Everybody else is just standing there looking, watching the event. Look at the same event in 2013. iPhone, iPad, iWatch, everything. Technology has invaded us. We haven't even realized. Today, the same event is a totally different experience than it was 10 years ago. Well, this technology that has come into our life has also come into our operating room. And now those old hysteroscopes that were thick and cumbersome were miniaturized and they changed the shape. And now we have a device that can be easily inserted into a woman's uterus without causing any pain. This is the reason why we need to stop the DNC, and we need to come up. I really feel we're in the Stone Age, and we gotta come out of that Stone Age, and hopefully we'll see the slide looking like this with totally abandoned blind procedures. About 75% of us doing hysteroscopy, probably a quarter of us doing intrauterine surgery. But why is this is not happening? And that is why I'm trying to think what is happening. Why so many limitations? Well, probably the first limitation will be pain, right? Pain is always an issue during hysteroscopy, but if we understand that there is three things that cause pain during in-office hysteroscopy when the patient is awake. One is getting through the cervix. If you move the cervix, that does cause pain. The second thing is distending the cavity. If you distend the cavity too much, that also causes pain. And the third thing that causes pain is when we touch the walls of the uterus. So if you pay attention not to do any of those three things, the hysteroscopy should not be painful. Another limitation that I might see is the anatomy, right? Yes, there are challenging. There is cervical stenosis. There are my fibroids that occlude in the canal and make the hysteroscopy a little bit more difficult to perform. But there is plenty of evidence that all you need is skills. You need to learn. You need to attend the courses. You need to listen to this kind of webinar that you're listening now. The literature is filled with tips and tricks on how to overcome whatever challenge the anatomy is bringing to you to do a hysteroscope. And the most important thing, and what I'm actually going to put my emphasis on in my talk today, is the quality of the sample. We're talking about possibility of cancer here, right? If we're talking about endometrial biopsy, because we're suspecting endometrial pathology. And we must provide the best quality for our patient, and we must provide the best quality of the specimen. Because you know that saying that says garbage in, garbage out, right? So if we provide a poor quality specimen to the pathologist, how are we going to expect them to give us an accurate and good diagnosis? That just doesn't happen. It's like try to tell somebody, well, tell me what do you see, and you provide what's there on your left, a bunch of pieces of a puzzle that are all disrupted, and you expect someone to tell you what the figure is. No. As opposed to if you provide an intact piece of specimen, it's way easier for the pathologist to give you a diagnosis. And this will be the correlation to the prior slide of the puzzle of the pathology, right? On the left, you have those little pieces, one here and there, and as opposed to on the right side, where you have a thick piece of tissue. Common sense will tell which one will be easier for the pathologist to give you an accurate diagnosis. So we need to pay attention to artifacts, so we can provide the pathologist with the best biopsy possible. And one of the most common artifacts is upscoring blood. And you get blood when you do a DNC, right? You throw everything in there. You throw tissue, clots, everything you collect from the uterus into that specimen bag that gets sent to pathology. Well, that is decreased when you do a hysteroscopy. Another problem is thermal damage. Sometimes when we use, and then we'll go over this in a second, we use electrosurgery to collect the biopsy. Well, that could cause some thermal damage and make difficulties for the pathologist to see the specimen. It's like when you do a leap. Remember when you do a leap, if you stay too long, you might burn the edges of the specimen. Same thing happens if you use electrosurgery to collect an endometrial biopsy. Another artifact that is very interesting and happens only when you do a dilation and curettage, it's called telescoping. What that is, it's interesting because if you do several passes, the endometrium bunches one inside the other, and the glands get all together just because you're passing over and over and you're like bunching the tissue, and it creates the image like there is many, many more glands. Whether there really are, it's just because they're bunching together because of the curettage. And the pathologists might interpret this as endometrial hyperplasia because of excessive glands. And this happens only when you do a scratch of the same area several times. And the other one is crushing, right? When you got the piece of pathology and it's crushed, then it becomes like that puzzles that you could not understand at the beginning. So what can we do? How can we avoid all those artifacts? Well, the first one is a punch biopsy, right? With good technique at the time of performing the biopsy. And the technique is, it's relatively simple. Once you elect the area that you want to biopsy, you just get your grasper, go in and push in. That's an important thing. You push in, grab your piece of the biopsy, and pull it out. And you pull it out without pulling the grasper into the operative channel. The other one is the plowing biopsy. Here is kind of the same with the punch biopsy, but this is the one that I actually recommend and I always use. You open the grasper wide, select the tissue, and you push in. You like move in like plowing tissue. See the amount of tissue that you're able to collect if you use this technique. Then when you're at the end, twist, push in, and bring it to the tip, and everything comes out, hysteroscope and everything together. But sometimes there is not much tissue to collect, right? There is just a lining like a very superficial area of cells. That is when you use the carpet biopsy technique. In this video of Dr. Haibovich, very elegant perform. He creates a carpet of endometrial tissue that he basically was doing is generating the specimen for him. But that also can happen when you have atrophy, there is no tissue. Then what you use the same technique. You use your scissors and you grab a piece. You kind of produce your specimen, right? You produce like a small polyp that is then easier to collect just using the grasper. Say in a second. So once you do with your scissors, you produce your biopsies right there. You see, so now it's like a little polyp. You come in with your grasper, and now you have tissue. It doesn't matter if it's atrophic endometrium. You do have a big piece of tissue that you can grab. Remember, twist, push in, and bring it out without bringing the grasper into the operative channel. You not only can use the scissors, you can use bipolar energy, as we said, or we can use now the mini resectoscope that is being used in an office setting to collect biopsy. But remember, this could create the thermal damage on the specimen, so you got to be very, very careful of that. But what are the pitfalls? I really want to show these pitfalls on the endometrial biopsy. And what is this? The atrophic endometrium, right? If you go in with a grasper and you have an atrophic endometrium and you expect to collect tissue, that's just not going to happen. See, here is, I purposely put my residents to try to do that. And she was trying and trying, she was getting frustrated, but no matter how many times she tried, you'll never get tissue because there is just none there. This is an atrophic endometrium. It's just cause bleeding and don't obtain any tissue. So that's important. The other important thing is this. When you're going to do a punch biopsy, let's say, right? You collect your specimen, as we said, and we're going to repeat this over and over. So you see, you kind of dig your grasper inside the tissue, collect, twist, as we said, and then a pitfall is you're there, you have your specimen, and then you retrieve your grasper inside the operating channel. Don't do that, because if you do that, you will lose the specimen. And all you get is just a little bit of specimen at the end. See, on the left, it's when you collect the biopsy and pull it out without introducing the grasper inside the channel. On the right is when you, by mistake, pull back on the grasper. And we proved this. We actually recently published it in the Gynecology Oncology that the grasp biopsy technique is the ideal way to collect biopsy for endometrial cancer. And we show that the adequacy of the biopsy sample was 100%, and most importantly, the concordance of the diagnosis was also 100%. When you see on the right, when the biopsy was taken using the grasping technique, it was concordant 98% of the time when the cancer was endometrioid, and a little bit less, 62% when cancer is not endometrioid. So this technique is better for endometrioid type cancer. And this is not only that, not only the type of cancer, the grading, which you know is very important for preoperative planning of the patient and to counsel of outcomes. See how it's 100% accurate for grade 1, 94% for grade 2, and 96% for grade 3. So when you give, when you apply statistics to that, see the sensitivity is 100%, specificity 100% with a 100% positive predictive value. So you can tell the pathology, the surgeon that eventually will do a hysterectomy or whatever treatment the patients need, that the biopsy is 100% accurate that what he or she will find in final pathology. And that information is really important for surgical planning and for counseling, pre-op counseling of the patient. So to conclude, where are we going, right? Are we in the right direction? And we need to look at the future. We need to stand on our knowledge and look at the future. And what's the future foreseen? Probably a visual DNC. That I'm gonna leave this for Attilio, who's gonna teach us what's ahead, because Attilio is always one to step ahead of all of us. So he will probably tackle us with that. But what I can tell you is the time has come. We need to come out of the Stone Age. Stop doing blind DNCs. The technology is here and it's the time for change, because our patients deserve the best of our care. And with this, I'm gonna leave this my business card. There is my email right there. Please feel free to email me if you have any question, anything comes up after the webinar. I'll be more than happy. Or if you want to come and visit, I'll be more than happy to have you here at the University of Miami.
Tony, before we continue, I would like to ask the questions.
We're not gonna go with
I know that everyone is waiting for Attilio, so let's create some exact attention. We bring the questions, and because we didn't ask any questions till now, and you should have. So let's ask the people, all the audience, and we have all the time more than 300 looking at us as we can ask the question. So Yami, whenever you can, just start. Yami, whenever you can, just send the questions to the audience, so we get the questions, and then Tony, I will give you back the introduction for who everyone is waiting for, Atilio. So the question, please.
Okay.
Sergio, I apologize. We have a survey which will be automatically sent to everyone at the end of the presentation. We will not use the questions right now. It's a survey for conclusion of everything in the end.
Okay.
Okay.
So people have to listen at me now.
Okay, but
no,
let me have the honor of introduce you, Atilio. So it's for me a really great pleasure and honor to introduce a guy that needs no introduction. I'm just going to say that he is the recipient of the Golden Hysteroscopy Award, not only one time, 2 times. And the Golden Hysteroscopy Award is given to the best work on hysteroscopy of the year. So someone who has won that twice, you know, just that itself tells you what he is. More importantly, he is a very good friend and an excellent teacher. And he's my paisano, if we can consider myself Napoletano, right? He has 2 qualities that is really important that you rarely find in someone. He is a spectacular surgeon and a very generous teacher. He gives away tips and tricks for free that you never find that in one person. So it's for me really good honor to present my great friend, Atilio. Atilio, the stage is yours, my friend.
So really, you make me embarrassed. So I'm red. So now, so I'm really embarrassed because you did me one of the best presentation, but you are too kind, probably because we come from the same generous city, Naples. And I'm really very honored that we did this webinar, and probably it's the first time that the last speaker has more time than expected. Usually the last speaker has just 5-7 minutes and he goes in the next session. So I'm really a little bit concerned because really I have seen 4 beautiful presentations, and I'm very proud that at the end, even if no one has seen the presentation of the others, we run the risk of overlapping, but everyone did his job in a perfect way. I have to conclude with this presentation that is very challenging, the real innovation, the visual DNC. But first of all, I would like to reassure all people that have sent me message, called me the last few weeks. Oh, Atilio, are you changing your credo? You are one of the pioneers of using miniaturized instruments. So I think that the main objective of this webinar has been to show that direct view technique should always be preferred over the blind technique. Whatever blind technique is used, this is the key point that you have to bring at your clinical activity. The second key point, and I want to reassure all people who came in my unit, the gold standard technique for performing a simple target eye biopsy is the use of miniaturized instruments, crocodile forceps, so forceps with pin, in order to do with the correct technique and to have an adequate specimen to send your pathologist. Then you can use scissors, you can use fantastic 5 French bipolar electrodes in case of atrophic endometrium, but miniaturized 5-7 French instruments are still the gold standard for doing a target eye biopsy. I'm always concerned when we use the word innovation, Because most of the time, innovations are not very useful. And people emphasize some innovation that at the end are not very useful for our clinical activities. But I would like that you reflect on the fact that innovation most of the time occurs when we build up and borrow on what comes before. So it's important that you understand which are the limits of the current available technique in order to produce and propose an innovation. And we have seen all the limits that Sergio explained in a fantastic way about DNC, the risk of complication, that you have to bring the patients to the operating room, the possibility very high of missing focal lesion. And please don't do DNC because you think that you can resolve the problem of heavy bleeding of Our Lady. The DNC has no therapeutic role. But coming back to DNC, DNC has an advantage that you can collect a lot of tissue, despite it is not very ordinate tissue, and it's full of blood. And then Tony said that the blood can hamper a proper histological diagnosis. However, DNC has a limit, which is the main reason, as an advantage, which is probably the main reason why people still rely on DNC. They think that because they collect a lot of tissue, the diagnosis is more accurate. This is false, but it's correct that you can collect a lot of tissue. We can perform biopsy with 5 French instruments, but how many times we have the instrument that is broken, that the grasping does not close the 2 jaws, that you have to come in and out many times from the cavity. And if you don't use the proper technique that Tony explained before, it's very frustrating when you send a very small specimen for your pathologist and the result is inadequate specimen. We know that since Gianpietro Gubbini proposed his 16 French mini resectoscope, then there is another 15 French mini resectoscope, because as Tony said before, there are many people who are more skilled in using resectoscope. I think that the advantages of mini resectoscope has been to bring the same surgical maneuvers that you use in OR, you bring in the office. Very ergonomic, very easy to use. We generally use when we want to do biopsy in the endocervical canal, when we want to have also representation of the stroma of the endocervical canal in case of endometrial carcinoma. But of course, you need to use electrosurgery. It requires surgical experience. We cannot use mini resectoscope every time we need to do a target eye biopsy. But I would like that you reflect on a concept that my master Stefano Betocchi always says in his presentation. A new technique can only comes when you have a previous new technology. So technology first and then new technique, if you apply the technology in the proper way. And we know that since 2005, I was not one of the greatest fan at the beginning of the intrauterine morcellator. Then we abandoned the word morcellator after all the mess with laparoscopic morcellator. The tissue removal device came in the market and came in our routinely hysteroscopic activity. Very easy to use, and the possibility of cutting and simultaneously aspirate the tissue. And many doctors started to use this device. I was not one of the first to use this device. But I think, the slides are not going.
It's freeze on the mini resectoscope.
Ah, so we are on the mini resectoscope. You see now?
No, the number 3 mini resectoscope.
Okay, if I go now, you see the new slide? Okay, now I...
No, freeze.
Okay, I...
Share and share.
This is the advantage to be a little bit experienced in topic, better that it happened to me than not to my lady Brunella. So I shared the screen again. So it should go now. You see a new technique or not? You see my screen?
No.
No. Let's do in another way. I stop sharing. Again, because I have the maximum connection, I put on desktop and I share the screen. And now I put the slide from, let me put from this. So you see now the screen, mini resectoscope working or not?
No.
I don't know why.
No.
Because okay, let me just put here. Again, I share the screen. I put here. No, I put here presentation. I put here. You see now, okay?
Now we see the mini resectoscope.
Okay,
yes.
Perfect. So we said about the mini resectoscope. So you have seen the video that is very easy to collect a lot of tissue, very ergonomic, easy. We use when we want to perform biopsy in the endocervical canal in case of a neoplasia, which is going to invade the endocervical canal. You know that for the last figure classification, you need also to have a specimen of the stroma of the endocervical canal. But of course, it needs surgical skill and the use of electrosurgery. It can be a little bit painful if you don't use in the proper way. And honestly, you cannot use mini resectoscope as diagnostic tool in your practice. But it's important that a new technique, as always, Betocchi says in his presentation, always comes when you have a new technology. So technology first, new technique after, if you use the technology in the proper way. And we have to see that in 2005, the tissue removal device that at the time were called intrauterine morcellation came on the market. I was honestly not one of the best fan at the beginning, but probably because I didn't know perfectly. And my key message when people come in my unit, first try the instrument and then you can say that is not good or it is good. And the ideal instrument does not exist. It's important that you apply the good instrument with good technique for every particular patient. But we understood that it was possible to cut and aspirate tissue in the same way. And I started to try. I am a fan, as you know, of the office surgery. So we bought in our institution only the miniaturized tissue removal device. And we started to use and to see advantages and disadvantages. We use not the speculum, but always with vaginoscopic approach. We have seen that it's very easy, and you understand because this device is loved by our younger trainee. You don't need to go in and out from the uterine cavity because sometimes vaginoscopic approach is not very easy for most of us. Of course, you don't use electrosurgery, and we have to admit that you perceive the technique as less dangerous, less risk of complication, and we used in office setting. Of course, in order to use in office setting, you need that the diameter should be less or equal to 6 millimeters. That's why that we only have in our institution the miniaturized tissue removal device. Honestly, we use this tissue removal device when we think that the pathology present in the cavity has multiple polyps requiring more than 20 minutes. And when you use your fantastic VersaPoint with the electrodes, it can be too much time consuming, or probably when you don't have the VersaPoint, you have only miniaturized mechanical instruments. But every time you think that the cutoff value of office surgery, which is time, which is 20 minutes, of course, you can save a lot of time with this tissue removal device. And the second indication in our institution is the retained product of conception. Then in last year, of course, reading the experience of other groups all over the world, we have seen that probably people like DNC. Why don't we apply a new technology, which is the use of tissue removal device, with an old technique, which is the DNC, trying to take the good that we have with an old technique, so the fact that you collect a lot of tissue, with a new technology, and trying to see if we can overcome, if we can overpass the limits of the standard available technique. It's important to understand, even in this case, because we have seen that the biopsy with 5 French, 7 French instruments is the gold standard. But when in our institution we use the visual DNC? When probably you think that the endometrium is homogeneously or inhomogeneously thickened, and when you think that you have to do biopsy from all the walls of the uterine cavity. Because it's very easy with the visual DNC. You just put the blade of your tissue removal device in contact with the wall, and then doing movements of rotation of 360 degrees, you can collect tissue from all the wall. And it's important because you don't need to go in and out from the uterine cavity, as Tony explained perfectly before, because if you put the grasping into the operative channel, at the end, you have only the small fragment in between the two jaws. That's why you have to come out, as Betocchi explained, 2005, with the grasping biopsy technique with the whole hysteroscope from the uterine cavity. With the visual DNC, what you are doing is a sort of curettage atraumatic, because you are not going into the myometrium, so you don't cause the pain that Tony said before that you cause when you are going to touch the myometrium. And then you can collect a lot of tissue. In another situation, when we use the visual DNC, is when we have associated pathology. You have a thick endometrium, and you have a polyp in the uterine cavity, as in this case. So you first remove the pathology, then you can change the basket where you collect tissue, and you can also collect thick endometrium from this uterine cavity. Sometimes you see that the quality of the video is a little bit different. You know why? Because sometimes you can use fiber optic technology. You have the advantage of a smaller instrument, but you lose a little bit in the quality of vision. Sometimes you use the 6mm Elite tissue removal device. You see better, but it can be a little bit more challenging to go in office with awake patients in the uterine cavity of Our Lady. Another situation, and keep in mind, I found this paper provided by my friend Massimo Luerti. I wasn't aware of this paper, but every time you have a benign polyp and you remove the polyp, keep in mind that sometimes there is an atypical area in the surrounding endometrium, and it's not very uncommon. See that in this nearly 700 lady, 7.3% had an atypia on the endometrium surrounding the polyp, and in 1.2%, there was also adenocarcinoma. So probably when you have multiple polyp, thick endometrium, keep in mind that visual DNC probably can help you to diagnose an underlying carcinoma or a typical area surrounding a typical benign polyp. And we are using the visual DNC also when we have a sort of high-risk endometrial hyperplasia. You see that these are two cases in which the histology was complex hyperplasia with atypia. And I have to tell you that the first lady in the upper part of the screen is a 28-year-old lady, and lady down is 34 years lady. So we are seeing a lot of endometrial carcinoma, well-differentiated complex hyperplasia with atypia in young lady. So the visual DNC offers you the possibility to collect all the thickened endometrium from this cavity, and at the end, we also put an intrauterine system releasing levonorgestrel in order to do what we propose as the standard fertility sparing treatment for well-differentiated endometrioid adenocarcinoma in women desiring pregnancy. And because I know that probably most of you are thinking, but the tissue removal device, most in case of high-grade endometrial neoplasia, can increase the risk of dissemination of malignant cell? No, please don't think that using the morcellator you can increase the risk of spreading the neoplastic pathology. And we have seen since Mario Franchini, who is the pioneer of the use of tissue removal device in Italy. We learned, personally, I learned a lot from this guy in Italy because he's very generous. He came in my institution, I think 5-6 years ago, and he learned me and my group how to use the tissue removal device. And once more, I thank Mario for all his taught in my institution. We have seen with the paper that he published with Pasquale Florio that the tissue that you send to the pathologist has good quality. There is no artifactual, thermal damage artifactories that Tony before says that can hamper the possibility of a proper histological diagnosis. And of course, you collect a lot of tissue just as a DNC from the uterine cavity without having the blood obscurating the possibility of a proper diagnosis. And when people say, yes, that the morcellation, using the tissue removal device, you cannot coagulate. But in case of heavy bleeding, have you ever seen heavy bleeding when you have thick endometrium, when you have endometrial carcinoma? Never. So in this situation, don't be scared. And personally, when you have myoma, this is another option we will discuss in one of the next webinars. But for endometrial pathology, honestly, I've never seen, and I think all of you, a polyp bleeding so much that you have to convert on the use of electrosurgery. And just to conclude, because we have no scientific data to prove that visual DNC can be a good option, we are conducting in our institution randomized trial in case of endometrioid and non-endometrioid adenocarcinoma between these three techniques of endometrial biopsy. Because in the paper that we did, me and Tony, a couple of years ago for endometrial carcinoma, we have seen that the grasp biopsy technique is very effective in case of endometrioid carcinoma. But when you have the non-endometrioid carcinoma, because probably has a growth towards the wall rather than into the uterine cavity, probably the diagnostic accuracy was not so high as for the endometrioid carcinoma. So probably the resectoscope or the tissue removal device, because they are able to collect even the basal layer of the endometrium, probably they can increase, but we still do not know. And then, because I think that we have the duty that we have to improve our clinical activity, together with my friend Stamenov from Sofia, Bulgaria, and with Sergio Aimovic, we are trying to demonstrate, but we have only written the protocol until now, that probably the visual DNC can be an option for misabortion. Because another problem is that we still do the blind evacuation with Karman cannula in case of misabortion. A lot of retained product of conception, a lot of post-surgical adhesion, a lot of repeated surgery, and everyone has this problem in our clinical activity. So probably the visual DNC can be an option even in case of misabortion. And I thank you for the attention, and I apologize for the problems that we had for my connection. Thank you very much.
A great presentation as usual, Attilio. So right now I will try to ask the questions. We have so many questions. I don't know if we will be able to go through all of them. So I will try to start. The first question they ask me, if when you perform a hysteroscopy biopsy, do you take samples from all the 4 walls in a routinary way? So any one of you who would like to answer?
Generally, you do the biopsy on the area that, if it's for oncological reason, on the biopsy that, on the area that appears worst. I always say, what appears worst deserves histology. But in case, for example, when you put an IUS in the uterine cavity for a previous complex hyperplasia with ATP or endometrial carcinoma, you see that the decidual effect of the IUS releasing levonorgestrel can make the endometrium appearing even worse than it was before that you apply. In this case, it's important that you perform biopsy from all the walls in order to see if the conservative treatment is effective or not.
I totally agree with you, Attilio. I mean, we have to take the biopsy, and we have to be accurate and take the biopsy of the abnormal area. I think it's a nonsense to take biopsy of all the walls of the uterine cavity.
There's one case with.
I want to add, because I saw the question also, and trust your biopsy and the direct visualization. You don't.
Tony?
Yeah, please. Can you repeat the question, Tony? You have a bad connection in your hospital?
He is freeze. We cannot see him moving. What he was saying, that more accurate in hysteroscopy, when you see pathology, you can go directly to that. That's the difference with blind procedures. I don't know, Tony, if you want to add, because we cannot hear you.
Oh, sorry. Yeah, I'm back. My connection jumped up. Yeah, what I'm saying, you have to trust your biopsy and the direct visualization. So there was a question, actually, after you do the biopsy and the direct visualization, do you perform a DNC? And the answer is no. I trust the biopsy that I'm taking of the worst looking area.
The same, I think, with chronic endometritis, because we used to take from only one area, and sometimes we saw that it looks like a very severe chronic endometritis. By the immunohistochemistry, it comes as negative. So our pathologists ask us to take from different areas, especially affected areas, in order to get more sample and to arrive to a more accurate diagnosis. I wanted to ask Brunella. Brunella, someone asked about what's the cutoff for the endometrium for postmenopausal women?
I showed the new paper from YETA group that take 3 millimeters for this cutoff in postmenopause also.
Okay. So, because until now, I believe we used to work with 4 millimeters in most of the centers as a cutoff of normally. So YETA say that it's more accurate 3 millimeters. And please, there's 3.
Yes.
They ask about, in case of PMB, postmenopausal bleeding, with a woman with a regular endometrium 2 millimeters, should we perform an hysteroscopy?
Yes, if we have more symptoms, more than one times, we perform an hysteroscopy.
So if she has a repeated episode of postmenopausal bleeding, even with less than 3 millimeters, we need to do an hysteroscopy, but it's the first one and not repeated, we don't have to go inside the cavity.
Yes.
Anyone wants to add anything? Luis, there is one question about amoxicillin.
The problem, Sergio, I think that the problem that we have to stress is that when we do the diagnostic algorithm, unfortunately, comes from some institutions, some groups, in which to do an hysteroscopy, you have to bring the lady to the operating room, or is perceived as very painful, invasive technique. I think that now, probably the best way to treat the lady is to think, if it's my mom or my sister, what I'm going to do? If I think that probably the lady is obese, the bleeding is a little bit strange after many years of menopause, and the endometrium is thin, but I want just to check that with a simple office hysteroscopy, less than 1 minute, I can see what is inside. I can show many videos in which the endometrium was perfect. You go inside and you find an area of carcinoma. So this is the problem, how to perform hysteroscopy, how to perform a target type biopsy. Of course, if I have to bring the lady to the operating room to do a DNC, I put on the balance, should I do or not?
You know that sometimes, sometimes I'm sorry, Sergio. Sometimes those protocols that are due by people who perform ultrasonography, there is a problem that they do not perform hysteroscopy. And they think, as you told before, that the hysteroscopy is a very aggressive surgery in the OR, and the patient will have to dilate and to use or a tenaculum, and so they usually sometimes don't know exactly how we perform this kind of hysteroscopy today. And I think that's a problem. We have the same problem with the surgery of the septum, with the treatment of the intrauterine anomalies. There is a discordance between medical people who perform ultrasonography, the surgeons, who are we, and the people who work in IVF units. Sometimes I think it's important to work together. People as Brunella, who perform 3D ultrasound plus hysteroscopy, ensure that she has an open mind in the use of both techniques. And it is important to combine those both techniques by the same people, because you can choose one and the other, and you can see the correlation between the hysteroscopy and the 3D ultrasound, so you can be more accurate. So it's not to be so closed and to talk only about 3 or 4 millimeters or just set a number, because it depends on the patient. I don't know if you, Brunella, agree with me about this point.
Yes, I agree with you. In our clinic, we have this possibility, but I show you before that we have we can perform ultrasound and diagnostic hysteroscopy at the same time. So it's easy for us to perform this diagnostic tool.
As you said, I believe that the right way to work, Luis, and that's what we are going through from GCH, is to bring the 3 areas together: ultrasound, IVF, and hysteroscopy, in order to accurate more. Luis, there is one question for you regarding the tamoxifen. I'm asking about if there is a need for every year in asymptomatic patients to perform ultrasound every year for the follow-up of tamoxifen, and if there is any thickness from that amount of millimeters that you should recommend an hysteroscopy or not.
Yeah, I'm sure. I think that the patients that are taking tamoxifen, that they usually have strict control by their oncologist, and they have sometimes more than a couple of visits per year. I think that they have to undergo to every year ultrasound just to check the endometrium. Usually we take a cutoff of around 5 millimeters, and of course, when we are talking about indications, if any of those patients have any bleeding, we have to go with another test that can be a biopsy, or I prefer to perform an hysteroscopy, If there's any symptom, if they're bleeding, we have to try to look for another test. 5 millimeters and a yearly scan, at least.
Brunella, people want to know what are the ultrasound tricks to evaluate better the endometrium. Any tricks to ultrasound tricks?
Sorry, can you repeat the question, because I have no audio.
Okay, if there are any tricks, ultrasound tricks, in order to evaluate the endometrium,
Okay. I show you some cases, some difficult cases to evaluate the endometrium. When you cannot visualize all the endometrium, you can start from the endocervical canal. And then moving up, you can follow the line until the fundus. And then you can measure the thickness in the most thick part of the endometrium, maybe on the fundus or in the central part of the cavity.
Perfect answer, just very clear. Attilio, I know that you also treat with fertility patients. They are asking if for fertility, how many samples do you take for histology, and if you send it also to microbiology, and how you preserve the samples?
Okay, we should speak for hours about this topic. So I have to tell you that even in this case, I was a little bit skeptical about the text for evaluating endometrial receptivity, the endometrial microbiome. Now I studied a lot about that. I think that there are many good opportunities to improve the pregnancy outcome of Our Lady. There is no rules on performing biopsy for all the walls. It's important mostly when you ask for plasma cell and people want to have an idea if there is endometritis. You cannot send to your pathologist a small fragment of the endometrium. Of course, even in this case, if you see the micropolyps, if you see the stromal edema, if you see the hyperemic area, do the biopsy on this area. And it's the same when you do a vaginal swab and you see that there is the vaginal discharge, you take with your swab this part and you send for cultural analysis. But there is no rules. I think that in infertility, mostly then in IUB patients, the integration between the macroscopic appearance of the endometrium and the cavity, together with metabolomic and genomic analysis of the endometrium, probably it will become the future in order to say to Our Lady if it's time to transfer the embryo or it's time to wait and see for a better endometrium.
Okay. I think, Tony, I have a question for you. They are asking me if you perform together with the diagnostic hysteroscopy, you use sometimes the ultrasound for guidance.
Rarely, extremely rarely. Well, the quick and easy answer is no. I might use ultrasound guidance if I'm doing a hysteroscopy on someone who had a prior history of endometrial ablation. Let's say if it's an Asherman, very difficult Asherman, I might use ultrasound guidance there, but no, the answer is no.
Okay, I believe that all of us who perform hysteroscopy think the same. That's, isn't it? Okay.
Because they are the last 10 minutes, the question, I don't know if Yami has prepared. There
are questions. There are 3 questions already here that people are answering to them. The 3 questions you sent. We have over 110 answers.
Okay,
already.
So please, guys and ladies, answer these 3 questions in order that we have a good survey from our community, despite probably the community that we have today, and not because it's not fair that we say, but having 300 people connected for 2 hours continuously. I was the last one, so I checked that the number didn't go lower than 300. So for all the webinar, it's a very great success. And I hope that this community of hysteroscopists and not hysteroscopists is going to become bigger and bigger. And I'm sure that the next virtual event of the global community will be another great success, because it means that people want to learn hysteroscopy, people want to change their mind, And probably people doing hysteroscopy or doing sonography are a little bit more open-minded than people doing laparoscopy. So it means that there is a real interest towards this technique, whatever instrument at the end you are going to use.
Perfect. I will ask Luis, because it's an interesting question about the biopsy. Do you believe that there is a kind of grasper better than others for the biopsy? Maybe, I don't know, the crocodile is better than others. What do you think about which is the best grasper for biopsies?
Oh, that's a question that will open, financial interest. A friend of us who have produced grasper that they claim it's better. There's actually a couple of studies that compare different graspers. But I think as a general rule, the grasper to take the biopsy, you want one who has like teeth, like I said, right, like a crocodile grasper. You don't want the one that's like a spoon. That would be the only thing, but they're all the same.
Okay. What do you think about using the tissue removal devices in cases of suspicious of malignancy? Attilio.
Okay, so I explain, I mean, mostly when you want to collect a lot of tissue, in order to have, I think that now hysteroscopy shouldn't give, when the endometrium appears neoplastic, even the not expert doctor can understand that this endometrium is not normal. What probably we are asking to the technique of hysteroscopy, even to give some additional information about the histotype, about the grading, and probably, I don't know if with mini resectoscope or with the tissue removal device, even about the minimal infiltration of the myometrium. I think that is important for a good pre-surgical evaluation of Our Lady. So I think that mostly when you have a lot of tissue necrotic in the cavity, because sometimes it's very difficult with the grasping forceps to take this friable tissue from the cavity, I think that having a device that allows you to cut and aspirate in the same moment, probably you can, but we have not proven this yet, can give more information for a better pre-surgical evaluation of Our Lady. Unmute yourself, Sergio.
Thank you. I have a question for Luis. We talked about it 2 days ago. They think what is the best device adapted to the different kind of pathologies of the endometrium: bipolar, tissue removal system, laser, mini resectoscope.
Wow.
So which is the best device for the yeah, I know we talk about it.
Yeah, I think that the best device is the one that you have at your clinic or your institution. Because sometimes we are talking about the last one, the most expensive, the most powerful, and and the real hysteroscopy sometimes is not that. Most doctors, they have a normal hysteroscopy with scissors and a grasper. I think that in the most clinic, they have a normal resectoscope. And if you don't have a resectoscope, you can take the urologist resectoscope. So those are the basic tools that we can find in any clinic. Today, there have been a big change in the hysteroscopy world that has been the miniaturization. To get the small diameter in the hysteroscope, in the resectoscope, even in the morcerators. And I think that the future will be like that. Morcerators is a great tool. It's a great idea. I'm sure that in the future will be one of the most useful tools that we have in hysteroscopy, but we don't have to apart the normal hysteroscope and the normal resectoscope, because sometimes we have to use those tools. So,
and the key message that we have to say is that mostly for young generation, don't think that because it's really easier to use there are no complications, no problematics. Every instrument has advantages and disadvantages. So you need a training for using the resectoscope, you need a training for using the tissue removal device. Then it's important that at least you know how to do a diagnostic hysteroscopy, because there are complications with all the instruments available. And most of the complications occur for polypectomy. So what does it mean? That people, for the easiest procedure, they do not understand that they have perforated, they go in the abdomen, they can create a mess. So complications are very uncommon when you do ablation, metroplasty, myomectomy, because you don't do these procedures at the beginning. With polypectomy, most of the time you think that technology can avoid training. Technology cannot avoid a proper training. That's why it's important that our philosophy in the global hysteroscopy community was that when we arrange a congress, we have 3 levels: basal level, intermediate, and advanced. And you cannot jump to advanced level. In laparoscopy, you don't do myomectomy as your first surgery, but you do salpingectomy, you do adenesectomy, and then you do the most complicated. It's the same in hysteroscopy, wherever instruments you are going to use in your clinical activity. Otherwise, people think that they have the tissue removal device, no electrosurgery, very easy, complication. That's why it's important that we understand how to use every instrument in our clinical activity. And this is the beauty of hysteroscopy, because in my unit, I have the 5 French electrodes, I have the tissue removal device, I have the mini resectoscope, and one instrument does not exclude the use of the others. It's important that you apply for the correct patients and for the correct pathology.
Perfect. Guys, we have only 3 minutes, so I'm going to go around 30 seconds, every one of you, to say your key messages and conclusions. So we start, ladies first. Brunella, please. 30 seconds, messages, conclusions.
Che deve fare?
So, I want to repeat that it's important to combine the 2 techniques, the ultrasonography and the hysteroscopy. And in our clinic now, actually, we can do it. So it's important for the diagnosis, but also for the treatment. Now we have started a new protocol also for the uterine malformation, where we we diagnose and treat at the same time these pathologies with the ultrasonography and the hysteroscopy. So it's very important to combine these 2 techniques.
Thank you. Tony?
Well, I would say trust your biopsy, forget about the DNC, and get skilled taking the biopsy, do the right technique, don't retrieve your grasper through the operating channel. And, keep it up and train yourself and keep joining to these kind of activities, and we all learn and try to teach us something.
Thanks. Luis?
I have one for the young people and one for the masters. For the young people, study, train, study, train, study, copy to Attilio, to Sergio, to Tony, to Brunella, study and train. And for the master, study, study, and study. So we have to learn every day, try to improve our skill, and not only in hysteroscopy, in laparoscopy, in ultrasound, and I mean in medicine. So that's my advice for all the people.
Attilio, 30 seconds. Unmute.
I have seen the results of the answer that we prepared. And of course, we have a bias in our community that we are an hysteroscopic community. So I would be surprised if most of us doing DNC or PIPEL or Vabra biopsy. The message is, do a biopsy always looking inside the cavity. Miniaturized instruments are the gold standard. But if you think that you are still a fan of the blind DNC, please at least do the visual DNC. So at the end, you can see what you are going to collect.
Okay, thanks. And I will give 30 seconds before I finish. I am a believer, and I believe that hysteroscopy, the same as cystoscopy, that all the urologists know how to perform a cystoscopy. So hysteroscopy should be something in the hands of all the gynecologists. So we all should know how to go inside the cavity, look at the cavity, and also perform directed biopsies by under direct vision. So I believe that we are starting the end of the era of doing blind procedures. And this one is the first stone in our way. And you are going to see more and more activities going in this way. So we are going to do things that are safer to our patients, more efficient, and with less damage. So from here, I'm going to end this nice webinar with over 300 people being here together. And we hope to meet you soon in more activities. And of course, in the next Congress during the month of May, all the Saturdays of May, you're going to have more of this. And we hope to see you there. And remember, it's also with Spanish translation. Thank you very much for your presence here. Guys, thank you for a great evening together. And I hope to meet you all again soon. And also to thank to our translator ladies, both of them, they were great translating. So thank you for your work also together.
Bye-bye.
Bye.
Bye.
Bye. Bye-bye.